Hi, everyone. Welcome to the What the Heck is Going On with IC webinar. Today's session features Doctors Karyn Eilber and Victoria Scott of the Down There Doctors. Special thanks to Femetry for sponsoring this webinar. We are so excited you're here with us today. Before we start, I have a few housekeeping items. Please note that this session will be recorded. The doctors will be answering questions that were submitted in advance. We won't be taking live questions, but participants can direct message the doctors at the link provided in the chat. Please stick around to the very end. There will be a pop quiz for prizes, as well as a coupon code shared. And finally, please complete the post-webinar survey. A link to the survey has been posted in the chat. It's time to get started. Without further ado, please welcome Doctors Eilber and Scott.
Great. Thanks so much for having us. We're really excited to be here. And there were a lot of questions submitted ahead of time, so we're going to try to get through them all. But my name is Karyn Eilber, and Dr. Scott will introduce herself when she starts her portion of the talk. We are both urogynecologists. We are urologists by trade, and we not only treat a lot of IC, we've actually had a lot of our research focus on IC, which is how we ended up here today. And so we're going to talk about something you've probably had run through your head before. It's like, what the heck is going on with my bladder and IC? Next slide, please. So everyone wants to know, what is the silver bullet for IC? If I could answer that, I would not be on this talk today. I would be receiving my Nobel Prize. So unfortunately, there isn't a silver bullet for IC, but what we do have, next slide, please, is we have maybe some lead bullets. So if IC isn't like many conditions that do have a silver bullet, and a lack of a silver bullet is frustrating not only to patients, but also to physicians. I mean, we want to be able to offer something to someone and solve their problem right away. But since there's not that case, I did steal a quote from someone that there is no silver bullet that's going to fix that. No, we're going to have to use a lot of lead bullets. So hopefully today we'll give you a lot of lead bullet ideas so that we can together create that silver bullet. Next slide, please. So the many lead bullets for IC, which we're going to review today, include a healthy lifestyle, reducing stress, getting adequate sleep, exercise, dietary modification, and even supplements. Next.
Hi, everyone. Like Dr. Eilber mentioned, my name is Victoria Scott. I am a urologist trained in urogynecology as well, similar to Dr. Eilber. I'm really excited to be here today and grateful for the opportunity to speak to you guys. So we're all very aware of the negative impact that stress has on our lives and on our bodies in general. And research has shown that particularly for patients with IC, stress can be a very bad thing. It can lead to a lot of flares and trigger symptoms. So understanding stress and the physiologic impact that it has on your body can hopefully help you to better minimize the impacts that it has on your IC symptoms. So we hope that you can identify some daily habits that you can use to help to minimize your daily stress, as well as some tools to help to use for acute stressful situations. So what is stress? It's a perceived threat that triggers the adrenal gland to make adrenaline and cortisol and triggers your sympathetic nervous system. So you've probably heard of the sympathetic nervous system as something that your body employs during a fight or flight response. So historically, we would see an animal that was about to eat us, and we needed extra energy to either fight that animal or to run away. And so the sympathetic nervous response that we have evolutionarily helped us to either win the fight or to run away and survive. So the adrenaline makes the heart beat faster, it increases blood pressure, and cortisol increases glucose, which our body uses as sugar energy. It also slows down our non-essential functions, so we can divert all our energy to fighting or running away. So cortisol impacts our immune system, the digestive system, reproductive, cardiovascular, musculoskeletal, respiratory systems, and even the brain's control over mood, motivation, and fear. Next slide. The body stress response is usually self-limiting. So the body creates the extra adrenaline and cortisol, and then we use it either to fight or run away. However, when we have more of a long-term activation of stress without the fight or the flight to actually get rid of those hormones, then they hang around longer and they can have detrimental impacts on our body's physiology. So long-term activation of the stress response increases risk of anxiety and depression, digestive problems, headaches, muscle tension and pain, heart disease, heart attack. It can cause high blood pressure and stroke. It can cause sleep problems, weight gain, and problems with memory and focus. Next slide. There's a well-known connection between stress and pain as well, as I'm sure many of you are aware. So when you have chronic pain, it's always on your mind. And this oftentimes will limit your activities, can make you feel angry, depressed, or anxious. Stress also makes chronic pain worse by increasing muscle tension and can cause muscle spasms. Increased cortisol for prolonged periods of time can cause inflammation, which in turn will also increase pain. Next slide. So decreasing stress and cortisol levels, fortunately, we have a lot of good evidence that there are very effective ways to do this. It's important to keep in mind that similar to when someone tells you, just calm down, stop being stressed and anxious, it really doesn't help. It's hard to talk your way out of being stressed or being anxious. So you really need actions to change your body's physiology in response to stress to help get rid of it and feel better. So we know that exercising regularly can help, and I'll go into this a little bit more later. Deep breathing, learning to limit stressful thinking patterns. This may even require the help of a therapist or psychiatrist. They can be very helpful for patients with chronic pain. Maintaining healthy relationships and having fun and laughing as much as you can. These two activities are important for helping your brain create the feel-good hormones like serotonin and endorphins, and these will help combat the negative impact of the cortisol and the adrenaline. Next slide.
Before we go on, someone put in a question that the echo was really bad. Are other people having an echo? I want to make sure we fix that before we go on. Anyone else? I guess we could do
I can try
chat. Okay.
Let me change my audio.
Oh, I don't know if it was me or you. It was just in the answer.
It sounds good on my end, but yeah, please let us know if you're having any issues.
Okay, still echoing here. Is that just one person or are other people having the echo? Not on my end. Okay. All right. Okay, I think thank you for the people responding. I think most people, it's okay. So we'll go ahead and move on. All right, so I'm going to go over sleep and IC. Thank you. I love, well, not to be sexist, but most people that are replying are women. I love women there. I was like, they reply so fast.
You're being so supportive. Thank you.
All right. Not surprisingly, poor sleep quality is really more the rule than the exception in IC patients. Clearly, IC prevents good sleep, and sorry about the typo, because of frequent urges to urinate and pain. And unfortunately, also, you get this vicious cycle where pain is disturbing sleep, and then the lack of sleep actually aggravates the pain. So less sleep results in fatigue, lost productivity, depression, and a lower quality of life. Next slide, please. Some sleep hygiene tips. Try to be consistent with the time you go to bed and wake up. That does sound kind of silly, but for those people who have kids, it's exactly what we do. Try to get them in a routine. Simple things like aromatherapy can really help. In my practice, I actually have a little aromatherapy machine with some noise so that people can relax while they're getting ready for their procedures. Avoiding alcohol. For some people, alcohol can make you sleepy, but unfortunately, alcohol can also aggravate the IC bladder. Keeping your room dark and cool so that you want to snuggle up underneath your blankets and be comfy and go to bed, which goes along with having a comfortable mattress. There's nothing worse than tossing and turning because you're so uncomfortable. For me, especially, not only do I have to wear comfortable pajamas, but I have to wear ones that are like joggers. I can't stand when I wake up and like my pajama pants are like halfway up my leg and part of my leg is freezing. Trying different sleep positions. Sometimes you don't realize you keep waking up because your neck hurts and that's what's waking you up. This is one that I have to admit I am guilty of. We really should turn off all our electronics. You know, when our phones buzz at night and there's a light, even if you're sleeping and there's no noise, you still might be woken up by that light. Guided meditation is a great thing. I personally use this. There are so many apps that, you know, they have this kind of monotone, repetitive voice, and it really does put you to sleep. If all else fails, I'll try to listen to something educational that always puts me to sleep. You could also consider melatonin. Although melatonin helps some people, it does cause the opposite effect in some people, but it's definitely worth a try. And you can even apply heat to your bladder or pelvic area if that's causing discomfort and not letting you sleep. Next slide, please.
All right, hopefully that echo is better, but please let me know if not. So as I mentioned, research shows that exercise really helps IC, certain types, of course. So we have to be careful about what kind of exercise you're doing, but certainly to help manage the stress, it can be very helpful. So exercise reduces our levels of cortisol and adrenaline. Again, it's allowing your body to get rid of that extra cortisol and adrenaline that historically we would have used up with either fighting or running away. It stimulates levels of endorphins, and these are natural painkillers for our body. They also help to elevate our mood. Like I mentioned, we do have to be careful about what kind of exercise you're doing if you have IC and pelvic pain. So thinking about ways that you can exercise but prevent pressure on your bladder or pelvic region. So swimming can be good for some patients. Yoga, Pilates, Tai Chi, that's employing the stretching of muscles and focus on deep breathing can be very helpful as well. It's also important to remember that when we say exercise, it's not like you have to jump into this really aggressive exercise regimen by any means, even if it's just getting out and walking 10-15 minutes a day. It's something, and that's really helping to decrease that cortisol and adrenaline levels. Next slide. So some other tips to remember with exercise: avoiding high impact exercise, heavy weightlifting, that can increase a lot of muscle tension in your pelvis. You want to avoid pelvic floor strengthening. So if you like Pilates, they're always talking about strengthening the core and pelvic floor. You want to be careful with those activities. Some of them can be helpful, but you don't want to increase the tightness and spasm in the pelvic floor tension. If you like doing exercises, just be careful about modifying the workouts. So if the class calls for 30 jumping jacks, you might want to do something less strenuous or with less impact, like walking in place or marching. Of course, listening to your body is very important. If you're having a flare or not feeling up for exercise, then doing something much more light is important. Being careful about sitting on a bicycle seat for long periods of time can also be helpful. The perineum or the bicycle seat area is right where all your pelvic floor muscles are, so that can be triggering. And you want to make sure that you're not too focused on just one activity where you're only using a certain muscle group. You want to maintain balance in your body with all your exercise. Next slide. Deep breathing. I love this. And if you haven't tried it before, you might think it's kind of weird and not very helpful. But I think it's really helpful on a daily basis, but then also to use when you do have a more stressful acute situation. And there's a lot of evidence supporting its efficacy. So deep breathing activates our parasympathetic nervous system, which counteracts the sympathetic. So whereas the sympathetic is the fight or flight, the parasympathetic nervous system is our rest and digest system. So it slows down the heart rate, decreases blood pressure, relaxes muscles, and helps improve digestion. One good deep breathing technique that I like that's especially good for helping to relax the pelvic floor muscles is called diaphragmatic breathing. So you want to put one hand on your chest, one hand on your abdomen, inhale through the nose, and you want to focus on expanding the abdomen as opposed to the chest. Because most of the time when we inhale, our chest expands. Try to expand your abdomen instead of the chest. Hold for 2 seconds, and then exhale slowly for 6 seconds. Another good technique is the 4x4 method, where you inhale for 4 seconds, hold for 4 seconds, exhale for 4, and then wait for 4 seconds, and then repeat that for a couple of minutes. And that's a really effective tool to activate your parasympathetic nervous system as well. Next slide.
All right, I'm sure this is one that everybody has some interest in. So I'm going to talk about sex in IC, or more like no sex in IC, if people on the webinar are unfortunately like a lot of my patients. Over 50% of women with IC avoid sex, which is not surprising. The types of sexual dysfunction that are associated with IC are dyspareunia, or pain with sex, low desire, which I don't know if that's intrinsic, or because if you know sex is going to hurt, how could you possibly get in the mood for that? Impaired orgasm, also maybe one of two reasons. One is when a woman orgasms, it is repetitive pelvic contractions of her pelvic floor, and this may be actually painful, or maybe the sex is just so painful you just can't get to orgasm. And then insufficient lubrication. This is not necessarily because the woman can't lubricate, but you have to be aroused in order to lubricate. And if you're having pain, it's really hard to get turned on, regardless of how hot your partner might be. Generally, improved IC symptoms correlate with improved sexual function. No surprise. Next slide, please. So how can you improve sexual function with IC? I think that a lot of women are just kind of told it's the way it is and they have to accept it, but don't just accept painful sex as the way that it has to be. There are things that could be done. I wish that Dr. Scott and I could promise every woman that there is, again, that magic bullet. Might not get you all the way pain-free, but we should ideally, you know, whether it's your physician, your physical therapist, get you at least to a place where it's tolerable and you can enjoy it. There has to be control of any baseline pain or vulvodynia as well as possible. We use a lot of vaginal anesthetics or pelvic floor muscle relaxants, sometimes just before sexual activity, sometimes on a regular basis, and then when the pain is under better control, then as needed. And also, you should feel free to be in control and tell your partner positions that don't provoke pain. Generally, you can find some position that is not as painful as others, and that is the one you have to focus on. You also need to feel empowered to control not only the position, but the speed and depth of any penetration. Next slide, please.
So diet and IC, there's a lot of evidence behind the impact that diet has on IC, so I'm sure everyone is well aware of this. Everyone has different triggers. I always tell my patients this because when you first hand them that IC diet, their face just drops because it adds more stress to their life to have to be so fearful about what they're eating and be so limited. So just remember, everyone does have different triggers. While we have general guidelines for triggering and safe foods, you have to figure out what your body likes and doesn't like. So one way is to try an elimination diet. So try to eat that bland diet for 2 to 3 weeks, cut everything out, and then slowly reintroduce foods. Keep a diary along the way so you can help identify what triggers your symptoms. If the elimination diet doesn't sound appealing to you, you could just keep a journal in general with your foods and activities, your drinks, and then that can also help identify triggers. In general, most bothersome food and drinks based on research are coffee and tea, sometimes both decaffeinated and caffeinated, artificial sweeteners, spicy food, and then of course alcohol. I didn't add that, but that's another one. Next slide. The ICA has a great website, including really in-depth description of bothersome and less bothersome or more favorable foods for patients with IC. So just to briefly review, some of the more bothersome fruits are going to be the more acidic ones: cranberry juice, grapefruit, lemons, oranges, pineapple, strawberries. For protein, anything that's processed can be very triggering. Dairy, try to avoid yogurt. For vegetables, the spicy things like chili peppers, or acidic like tomato. And then for condiments, processed foods, so the horseradish, chili, ketchup, salad dressing, soy sauce. More favorable fruits: apricots, bananas, blueberries, dates, raisins, and then vegetables, things like avocados, asparagus, beets, etc. Next slide.
So since your diet is limited a lot of the time when you have IC, are there things that you potentially can do to help your diet or just help you overall? And so we're going to talk now about what's the role of supplements in IC. So we actually did an online survey and found that 40% of IC or painful bladder syndrome respondents actually took supplements. And I'm sure a lot of the people on the phone on the webinar here do that as well. Another 35% of respondents would be somewhat, very, or highly likely to take a supplement. And supplements were the fourth most common management strategy after diet, medications, and reduction of sexual activity. Next slide, please. So what supplements actually make sense with science? There are several ingredients that have relatively good data to show that they can be effective with IC. And these include quercetin, glucosamine, hyaluronic acid, pine bark extract, ashwagandha, calcium glycerophosphate, sodium bicarbonate, and aloe. Next slide, please. Quercetin is a naturally occurring anti-inflammatory. It is also an antioxidant. In a double-blind placebo-controlled trial, it showed that it reduced the symptoms of interstitial cystitis. And quercetin is an ingredient in a supplement shown to help refractory IC. Quercetin is actually very interesting. The person who led the study of the double-blind placebo-controlled trial was one of my professors, and they actually were looking at the use of quercetin in transplant patients because they found that it really helped to reduce that inflammation that is associated with transplant. So it's actually quite a fascinating ingredient. Next slide, please. And glucosamine and hyaluronic acid. Probably you've heard a lot about this gag layer, and this is the predominant theory of IC, and I do ascribe to it. There is a thought that there is a loss of the glycosamine glycan or gag layer. And this gag layer, if you can replenish it, can help with symptoms. So if you think about the gag layer, it makes the bladder this impermeable layer. The urine itself is full of all sorts of toxins and all of our waste products. So you can imagine that things like that, if there isn't a layer in the bladder that prevents all of those toxins from going into the deeper layers, that if that layer has been somehow compromised, which is a theory of IC, that's why people get this bladder pain. So hyaluronic acid is a glycosaminoglycan. Studies of hyaluronic acid and IC show symptom improvement rates between 30 to 85%. And glucosamine is a building block for gags. And some people who've had installations on this webinar, heparin also is used in installations because that also is a glycosaminoglycan. Next slide, please. And this is just a schematic showing theoretically what happens when the gag layer, again, has been violated. So you can see on the right that when the gag layer is not intact, it allows certain things to go through the bladder wall. And just looking at this picture with that loss of that little blue layer, which is the gag layer, you can imagine how that would cause such irritation. And a lot of people, unfortunately, are probably relating to the image on the right. Next slide, please. Pine bark extract. This is also another natural anti-inflammatory and antioxidant. It's also naturally antimicrobial. It's a procyanidin. Some supplements that are out there to prevent urinary tract infections, and in fact, the ones that I think that are most effective have procyanidin. There is a clinical study of 64 subjects with either urinary tract infection or IC showed significant decrease of UTIs and pain. So if you're one of those people who suffers not only from IC, but also UTIs, pine bark extract is a great ingredient. Next slide, please. And ashwagandha, lots of people probably heard about this. It's an adaptogen that helps modulate the stress response. And Dr. Scott was talking earlier about how important it is to manage stress. It also has a relaxing effect. It can counteract stress and lost sleep because stress can aggravate IC as well as a lack of sleep. Next slide. And then calcium glycerophosphate and sodium bicarbonate. They both neutralize acids. Studies show that when used together can reduce sensitivity when triggering foods are consumed. I have patients who will take sodium bicarbonate, which is kind of like baking soda. And, you know, we all have our addictions. I'll put it in their coffee or something so it makes their coffee tolerable for them to drink. Next slide. And aloe, it is broadly accepted as an anti-inflammatory, right? We all get sunburn. We put aloe gel in our skin. It has wound healing properties. So for that percent of people who have ulcers in their bladder, I think aloe can be really good. A lot of these things that I'm talking about, in medical school, we are not taught about supplements. We're not really taught about alternative medicine. I am unfortunately a lot older than Dr. Scott, so I've heard a lot more. But I have, over the years, I think some of the best things that I now recommend to my patients are things that my other patients told me. And things like aloe juice, aloe capsules, people told me about. Research has actually shown that aloe increases the amount of the glycosaminoglycan molecules. Next slide, please.
So, like Dr. Eilber started off our talk with the introduction of the fact that unfortunately, there is no silver bullet for IC. We really wish we had one. But because of that, it makes it a really frustrating disease, obviously, for patients like you who have it. It's also extremely frustrating for us to not have a good, effective treatment options for everyone that we can make patients happy with. So we really have, with our combined 50 years of clinical experience, learned so much from our patients. They come to us oftentimes, as you have, I'm sure, with a lot of frustration. Maybe they were misdiagnosed. Maybe they've been made to believe all the pain is in their head. Or maybe they've been given treatments that have really bothersome side effects. And so a lot of our patients have said, hey, I've taken things into my own hands. I've talked to other people with IC on social media, online forums, support groups, and I've learned about these certain supplements or different things that work well. And so we've gotten really interested, obviously, in things that we didn't necessarily learn about in medical school. So we were fortunate enough to work with a gynecology resident or gynecologist in training who had the opportunity to see our frustrated IC patients, to observe our challenges as well with making them happy and get their symptoms under control so they can live happier, more fulfilled lives. And she also had conversations with a lot of IC patients about their success with supplements. And she happened to know the founder of a supplement company and said, hey, you guys have to meet. And so she connected us, and that really started our years-long partnership of working together to try to formulate and create supplements using scientific research and evidence that Dr. Eilber has mentioned, as well as what our patients tell us and our clinical experience. So we are really excited about what we've come up with. The brand, all the leaders are very passionate, as we are. So it's been a great project, and we're really hoping that it will be helpful for a lot of patients. So with that said, we would like to turn this over to your questions. Next slide. We really had so many questions, so we're not going to be able to get to all of them, but we tried to pick ones that would be most applicable to everyone here. All right, so we're going to read them off here. I'll start. So there was one great question. Are there any clinical trials going on right now? When might a drug come up that is more successful, help the majority of patients? I understand everyone is different, but I guess what I'm asking is there a magic bullet? So no, unfortunately, no magic bullet yet. But obviously we're hopeful that there will be more money, more resources directed to research that we really need on IC, so we can come up with better treatment options. So I did a quick search on NIH clinical trials website, and this is a good resource. So I just looked for active studies that are looking to enroll patients. Of course, there are some on like urinary biomarkers, genetic and histopathologic characteristics of IC, and these are going to be really helpful for us in understanding the disease better. But there are also some studies on more behavioral modifications, mindfulness and yoga, and then some procedures, PRP injection, intravesical Botox, hyperbaric oxygen, and then some interesting ones using Humira and other injectable anti-inflammatory drugs, like those that are used to treat rheumatoid arthritis, Crohn's disease, and psoriasis. So I think there's a lot of good research out there that's being done. It'll probably take a little while for it to kind of come down the pipeline and give us that magic bullet. So for now, I would say just continue this more of a multimodal approach and try to use a lot of the things that we've talked about.
I'm going to use this as a shameless plug. So myself and Dr. Anger, who could not make today, we are both investigators currently for a clinical trial looking at the use of Botox for interstitial cystitis. So some people on the call or on the webinar today may have had Botox injected because of the frequency and urgency associated with, but Botox likely has some effects on pain, which is why it's used for migraine. So if anyone is either in the Los Angeles or San Diego area, or you're willing to make the trip, both of us are currently recruiting for that, and recruitment will probably go on for the next 6 to 12 months, I'm guessing. The only thing that is a little rough for some of the IC patients is I think can't have had a hydrodistension or an installation for 3 months before the study. So some of my patients just can't stop their installations because they're just afraid to have too much of their flares. But anyway, I will stop promoting myself and I'll go to the next question, which is what happens when an IC patient has to take a medication like chemo, but it flares them too badly to take it? Ironically, sometimes things like chemo, because it affects your immune system, might help your IC a little bit. But if patients really have to have medications or other treatments to aggravate their IC, hopefully you're someone who responds to installations. So I do have some patients who will preemptively have installations, and they know that they're going to travel or have something stressful come up. A lot of people will preemptively do some installations like that. Again, I wish we had a magic bullet to recommend for that, but except for kind of preventative installations or anything that helps, like loading up on, aloe or anything else that can help with your flares, I probably take them before you get this medication to help prevent a flare.
Next question, why are my symptoms worse at night? So this is common for many types of pain. In fact, a lot of researchers have coined the term painsomnia because it's a well-known phenomena, but we don't necessarily know why, to be honest with you. So it may be due to changes in hormones and cytokine levels that happen in kind of a circadian rhythm. It may also be partially because you're just you're less distracted at night, and so it's easier to concentrate on your pain, and this can kind of create a vicious cycle. But unfortunately, we don't know exactly why, but I can reassure you that it's very common. A lot of patients experience this issue, and it's helpful to keep in mind as you're kind of organizing your day, and maybe using some more tips that Dr. Eilber mentioned for sleep hygiene, or if you use any supplements or medications for your IC, maybe trying to target those more in the evening time so they're most effective at that point can be helpful.
All right, next question was, please give your thoughts on bladder Botox for the painful urgency and frequency associated with IC BPS, especially for the central sensitization subtype. So just to give the disclaimer, we can't give you medical advice because we're not your actual physicians, but the fact that I am participating in a bladder Botox study for IC, I do think there is a role. If it is used currently, it is off-label, so hopefully the trials will show in a way that is satisfactory to the FDA that it does get indication for that. Specifically for the central sensitization, that's tougher. I think that if it's bladder centric, I think things like installations, things that are focused on the bladder help. When someone really has a central sensitization issue, I think that's where you probably have to use more systemic medications, things like Neurontin or gabapentin, maybe some antidepressants, things that actually act at the central pain receptors. But I think that if the bladder is causing pain, which eventually results in central sensitization, ideally, if you get the bladder pain under control, then maybe these medications that are for the centralized symptoms can be more effective.
All right, next question. Does pelvic floor therapy help with IC? And our answer is absolutely yes. Interestingly, in our American Urologic Association guidelines, which are guidelines created by all the top experts in IC in the country, compiling all the current evidence that's available. There's really the highest level of evidence in support of the efficacy for pelvic floor PT in helping patients with IC symptoms. And this is likely because a lot of bladder pain can cause spasm and tension in your pelvic floor muscles. There may even be some people that start with the actual muscle pain and tension first, and then that causes the bladder pain. We're not really sure. But physical therapy, the same way that it helps with a knee injury or ankle injury, your pelvic floor muscles are a hammock of muscles that support the bladder. So these muscles need a lot of attention as well sometimes when you have pelvic floor issues. So pelvic floor physical therapists are a fantastic resource to help patients with IC.
Yeah, I don't even know how I would manage not just IC, but any pelvic pain patient without the physical therapist. And we're just lucky these days there's more, because when I started practice 20 years ago, you would be lucky to find one, even in the entire LA area. It just really wasn't a thing at that time. All right, next question is, sometimes I feel like it is all in my head because there is no direct cause. Is that normal, even though I'm in pain? Well, I would venture to say you think it's all in your head because someone probably made you feel like it's all in your head. Certainly, stress can aggravate any existing pain. So the question is, like, how much is the actual pain that has been made worse by other things that are in your life, like stress, maybe inadvertently doing exercise you don't know is aggravating it. But you should not feel like it's in your head, because that's just, I think, gaslighting.
All right, next one is, can tight pelvic floor muscles cause urinary retention? So yes, in its most kind of pathologic state, there's a condition called Fowler's disease, where it's basically urinary retention that's due to such severe pelvic floor muscles. And this is oftentimes found even in children or young women who have such tight pelvic floor muscles that they cannot relax to allow urination. Sometimes it is triggered by stress, oftentimes, and we see this actually I've seen it in a few IC patients. Yeah, I think the ways to manage it, of course, pelvic floor PT, figuring out how to relax those pelvic floor muscles, sometimes with the use of muscle relaxants, or vaginal suppositories, things that can help.
Sorry, I'm trying to type answers, the ones I got sent in the chat at the same time. All right, next question is, what is the difference between IC and Hunter's disease? Hunter's ulcers are just a subset of people with IC. About 9 to 12% of people with interstitial cystitis have Hunter's ulcers, which if you biopsy them, they just show a lot of inflammation. People with Hunter's ulcers will sometimes have them burned or fulgurated or sometimes injected with steroid. But yeah, Hunter's disease is not a separate entity. It is a small subset of IC patients, which sometimes are a little harder to treat because they do have these lesions that are there.
So next question, when is bladder removal or any other major surgery required for IC? So bladder removal or cystectomy is a huge operation. So it's definitely should not even be considered until you've really tried all the medication options, the less invasive treatment options, bladder installation, hydrodistension, possibly even Botox, neuromodulation. You've used your team, pelvic floor physical therapist, pain management, and then possibly, GI, colorectal, any other doctors to help manage all your pelvic issues. We know that the tricky thing with the cystectomy, and the reason why we have to be so careful with it, is that and research has shown this, that a number of patients don't actually have improved pain symptoms and can have even worse symptoms, even after you remove the bladder. And this is likely because their nervous system and all the nerves have been so triggered by their chronic pain that they still perceive pain even though the bladder is gone. We do know that patients that do tend to respond better to a bladder removal are going to be patients with really severe Hunner's lesions, or those who have a really fibrotic contracted bladder with a small capacity. So patients whose bladders just cannot expand, and they've really become kind of these end stage bladders, as we refer to them. But I must say, though, if you are considering the cystectomy or bladder removal, make sure you're at a very high volume center. So someone who's doing these operations a lot, because it is a big surgery. And so you want to make sure that you're certainly in the best hands.
And the next question is, can IC be misdiagnosed and actually genitourinary syndrome of menopause? Absolutely, and we see it all the time. So in fact, it would be very unusual to have, say, a 65-year-old woman for the first time in her life get diagnosed with IC. That's just not kind of statistically how it happens. And also just be much more common, say, a woman who is 65 and not taking any hormones and start having all these bladder symptoms and other things, for it to be a lack of hormone than IC. So absolutely, personally, and I'm sure Dr. Scott has too, I have seen someone get diagnosed with IC who had either something else or did have genitourinary syndrome of menopause.
All right, how would you treat if there's both a tight pelvic floor and a weak pelvic floor? This is a great question. 100% pelvic floor physical therapists. So you really want to make sure that you don't start with the strengthening part, because that will really make everything worse. First, you want to address the tight pelvic floor. So working on reducing that muscle tension, spasms, and once you've really gotten that under control, then slowly, very slowly starting to work on the strengthening components.
All right, what soap to use in the vaginal area that doesn't cause burning flare issues? You know, I try to tell patients, use something like they would use for babies, you know, really no perfumes, something really mild. I think the most important thing really is no, and most people are probably familiar with what clean beauty is and avoiding like certain chemicals that can be irritating the skin. But I think if you want a good place to start, literally go to the baby care aisle and find something that, you know, is really non-irritating and doesn't have any kind of scent.
All right, I cannot take anything with vitamin C, including a vitamin, or it turns into a flare. Is this normal? Yes, so vitamin C is ascorbic acid. So again, anything acidic can absolutely trigger IC symptoms. So I guess in terms of management, no, that's a trigger. So just be really careful about trying to avoid it. And then if you feel like you really want to have something with vitamin C, or you've accidentally had something, trying to take something like the calcium glycerophosphate that can help kind of neutralize the urine can be helpful.
All right, if there are both androgen and estrogen receptors found on the bladder wall and urethral wall, and both are diminished hormones in menopause, couldn't that cause an irritated urinary symptom? Is that IC or GSM or both? Yes, absolutely. Lack of hormone can cause that. In fact, vaginal estrogen is recommended quite a bit for bladder pain symptoms in menopausal women. Again, in someone who doesn't have a history of IC and they are menopausal, and this is when they first having symptoms, although it's not impossible, I would think that it was more of a hormonal issue than IC, and I'd probably start with some type of local hormonal replacement first.
Next question, is a cystoscope or cystoscopy needed if an ultrasound ruled out kidney, bladder, and urethral concerns when there's microscopic hematuria only during IC flare? Okay, so I think this question is referring to, number one, I'll break down microscopic hematuria. So this is blood that's found in the urine, but only on a lab test. So you don't actually see blood with your eyes. It's just when the urine is sent to the lab, they look under the microscope and they see red blood cells. And the standard workup for blood in the urine in the absence of infection is going to be imaging to look at the kidneys. So ultrasound, or a CT scan, and a cystoscopy, which is a camera test to look in the bladder. So I think this patient is asking, you know, they're having a flare and they were found to have the microscopic hematuria. So do they still have to undergo the whole workup? So technically, yes, if there's no infection at the time, then our recommendation would definitely still be to take a look, even if you are having a flare. I guess an exception could be if you have known Hunner's ulcers, but still the safest thing, especially if you haven't had a cystoscopy before, is going to be to take a look, because it could be something unrelated to the IC flare that's actually causing the blood in the urine.
All right, next one. This one kind of makes me a little sad. Is there an established protocol for urogynecologists for treatment? It just seems kind of like an experiment at times. Also, new meds are introduced by companies, but prices so high. Yes, and I'm guilty of it. I do feel like sometimes it is a little bit of an experiment because we don't have that magic bullet, and we try our more common lead bullets. When I am going a little, I'll just use the term loosely, off label, you know, you do have to have that discussion with your patient. There isn't, unfortunately, an established protocol, but I think that most people will be conservative. There are guidelines from our professional societies, the American Urological Association, but, you know, depending on what you've responded to in the past or had a bad reaction to, sometimes you can't follow that straight algorithm, and we do have to think a little bit outside the box. So I don't like that people think we're experimenting on them. We are trying to find things that can be helpful. But yeah, outside the guidelines, there is no established protocol per se.
All right, is there a cure for IC by detoxing your body and getting your thyroid and hormones in check? So cure, no, unfortunately, no cure for IC. In terms of detoxing your body and getting your thyroid and hormones in check, I would say, you know, definitely as a part of your routine checkups with your doctor, make sure that they are checking thyroid. This is pretty common. Checking estrogen, progesterone levels isn't always a part of like a well woman exam, not even necessary, for example, if you think you need hormone replacement therapy, but that's kind of another topic. In terms of detoxing your body, I would say focusing mostly on the diet might be most effective there, and try an elimination diet, identify foods that are triggering for you. I think that's how I would answer that one.
All right. Does eating high potassium foods cause IC pain or flares? That's a good question. I think that if you happen to eat foods that are high potassium and acidic, that's definitely going to cause a flare. Theoretically, and I'm saying theoretically because people haven't really looked at foods high in potassium, but back in the day, a potassium sensitivity test used to be performed for people. It's not that commonly done anymore because research is kind of equivocal over time. But if you had potassium put inside the bladder, not ingesting it, putting it in the bladder, and you had bladder pain, that was supposed to be diagnostic of IC. So that's what I'm saying. Theoretically, high potassium foods might aggravate it, but I don't really have good scientific data to tell you yes or no about that.
All right, is interstim therapy recommended for urgency and frequency associated with IC? So interstim is sacral neuromodulation. This is a FDA-approved treatment option for overactive bladder, so urinary urgency, frequency, with or without incontinence. Not necessarily for pain. It's also used for fecal incontinence or non-obstructive urinary retention. So it's not necessarily FDA approved for IC, but it actually is in our guidelines as a recommendation. So if you failed or not had a good response to hydrodistension installations or other slightly less invasive options, it is recommended as something to consider trying, particularly if your IC symptoms, or the most prominent ones, are the urgency and frequency. I think, we have seen it really improve patients' pain, but again, it's off-label to use it for the pain. You have to really use it when you're counseling patients for the urgency and frequency. It's in terms of looking at efficacy in improving urgency and frequency, again, in a non-IC patient, 75 to 80% effective. But again, we don't really have the data in IC patients. That being said, personally, I think it's a great option to try. It's pretty minimally invasive, certainly before you consider something like a cystectomy or a bladder removal, or if you've really been, suffering despite trying a lot of other options.
All right, we have just about a handful more of questions we're going to go over, and then we'll do the contest. I'm going to combine the next two just because they're very similar. I've been receiving triamcinolone bladder injections for Hunter's ulcers, which is a steroid, about every 6 to 7 months for 5 years, wondering about side effects, and then if there's any new treatments for Hunter's ulcers. Theoretically, because the triamcinolone is only being injected locally, it shouldn't be the same as if you were taking steroids by mouth, but the Hunter's ulcers, by definition, are not an intact bladder lining. And also, if someone's injecting into the bladder wall, there could be some systemic absorption. Having said that, if you're only having it every 6 to 7 months, anything you got into your bloodstream should be gone. So there should not be any long-term side effects with that. And there really aren't any new treatments for Hunter's ulcers. We still kind of do the same thing, which is either burning them or injecting steroid into them.
All right, so besides the basics of good hygiene and peeing after sex, what is your best advice for having successful penetrative intercourse with IC? So with respect to the pain component, I would say definitely pelvic floor physical therapy is going to be a huge or very important treatment in your regimen. Dr. Eilber mentioned some really good other things to keep in mind, that just general control of your IC symptoms are going to help you to be able to tolerate and enjoy sexual intercourse more. Probably the good hygiene and peeing after sex. I'm not sure if this person is referring to preventing infections, because that's usually what we advise patients with respect to avoiding infections triggered by sex. I would say, certainly if you're finding that it's just a flare triggered by sex, then don't necessarily go the UTI prevention route. But if you are having flares, it's important to have your urine checked each time to see, is it a flare or is it actual infection? Because that's a really tricky area, as I'm sure a lot of you have kind of come across. Is it a flare or is it an infection? So to that point, I would say definitely making sure you check your urine each time so you can confirm which approach do you have to kind of focus on.
All right, next question is why the majority of urologists I see not believe that IC is a valid complaint. I think you're seeing the wrong urologist, sadly. Or maybe they just don't have a good way of treating it. So maybe it's a subtle way of not having you come back. Most of my colleagues and circles that I run in, everyone believes that IC is a disease. The issue is, how do we effectively treat it?
Yeah, I think that's a really good point, that if you don't have good treatment for something, then you probably, may try to make a patient feel as though the symptoms are all in their head because they just don't know how to treat it. So it's probably a good way to look at that one. After my first pelvic floor session, I ended up in horrible pain for a couple of weeks. So how do you prepare patients for the possibility of a large pain spike? That's a really important point. Certainly, I think for most IC treatment options, I advise my patients, look, this can cause a flare in your symptoms. So same goes for installations or the hydrodistension. Oftentimes things are going to get a little worse before they get better, because we really have to try to help get that bladder muscle more relaxed and stretched out, get those muscles more relaxed. So I think, like you mentioned, preparing patients for this possibility is helpful just in terms of expectations. And then in terms of preventing it, certainly loading up on all of their treatment options or ways to help manage symptoms kind of before going into that situation can be helpful.
All right, I think we'll do one more and then we'll wrap it up. It's going so fast. Let's see. Well, we kind of went over this. Do you think ICE symptoms can fluctuate due to hormones? Very much so. I would say that if your symptoms vary with your hormones same time every month, you have not been evaluated for possible endometriosis, you have to consider something like that. And then what do I think about estrogen therapy? It depends on if someone is premenopausal or postmenopausal. So in a younger woman who has fluctuating symptoms with her cycle and there's a thought that she has endometriosis, the only way to definitively make that diagnosis is to actually look inside of someone's abdomen, but you can indirectly make the diagnosis if being on birth control and the cycles are controlled, that the symptoms are controlled. So this person who submitted the question was 25 and they were diagnosed with IC, only had symptoms improved after getting pregnant, which a lot of people do report. Symptoms after pregnancy have been mild up until recently, age 52. So the main hormone during pregnancy is progesterone. So this is someone who might think about taking estrogen and progesterone and maybe taking a little higher dose of progesterone if indeed their symptoms got worse with menopause and they felt better during pregnancy, because that is the predominant hormone. And lots of women will report that during pregnancy was the only time that they actually felt better with their IC. All right, I think we're going to pass this off to the team who is much more technologically advanced than we are to run the contest. See, Jake or April, are you guys? There it goes.
Hi, sorry about that. Okay, so we are going to play a little game of Kahoot. If everyone wants to go to kahoot.it on your computer or your phone, what you can do is you can type in this game pin here, and to get started here, as soon as we see everyone's names pop up, you can just put in your name and nickname, whatever you want to do. And we're going to test your ICIQ. So winners will receive, the top 3 winners. The winner will receive a 3-month subscription to our Femetry bundle. Second place will receive 2 months, and third place will receive 1 month. And for everyone, we will have a discount code for you. So that would be webinar 10. If you go to femetry.com, you can see all of our products and check out. When you check out, use webinar 10 and you'll receive 10% off. I'm just going to wait a couple more minutes for everyone to log on. So speed is a factor here. So if you are seeing the answer, type it right away or click on it right away. Okay, just about 30 more seconds and then I'll get it started. All right, we have 34 participants, 35. All right, let's go ahead and get started. Okay, first question is, what is a side effect of Elmeron? Infertility, irregular heartbeat, hair loss, or weight loss? One more second. Okay, looks like we have 17 correct answers. All right, moving on. Got our top participants here. Okay, all of the following conditions are associated with IC except stomach ulcers, fibromyalgia, irritable bowel syndrome, or vulvodynia. Okay, correct answer is stomach ulcers. All right, moving on. Got our top leaders here. Okay, now the following ingredients are commonly in bladder installations except Botox, bicarbonate, lidocaine, or heparin. Two more seconds. Correct answer is Botox. Okay, just a couple more. All treatments below are recommended for IC except hydrodistension, long-term antibiotics, pelvic floor physical therapy, or fulguration of ulcers. Okay, got 30 correct answers here. That is long-term antibiotics. Okay, last question. True or false? Cystoscopy is required to make the diagnosis of IC. Okay, last second, and it is false. And we have our winners here. Amanda M is in third place. CK second. And our winner is Tiff. Thank you guys, everyone, so much for playing. Runners up are Kate and Kat. All righty. And I'll turn it back over to Jenlene and Victoria and Karyn.
Great. Wow, this has been an amazing discussion. I've learned so much, and I'm guessing our attendees did too. Doctors Eilber and Scott, thank you so much for sharing. And thank you so much to Femetry for bringing these incredible experts to our community. If you found this event to be of value, please consider joining us for future webinars and share these opportunities with your community. And if you haven't already, please donate to the Pain to Purpose event or sign up to fundraise. Your support allows us to continue to bring you amazing programs like this. Go to ICA's website at ica.org to learn more about how you can support the ICA during IC Awareness Month and beyond. A friendly reminder to please complete the post-webinar survey that we have posted in the chat. Thank you so much for joining us today.
Thanks, everybody.
Thank you.